Welcome, and thank you so much for joining the NEC Society's webinar on advancing equity for mothers and babies. This webinar is dedicated to Sal, and his mother is going to be joining us in just a moment to share his story and her family's story. So we're really honored to have them. I want to recognize Engage, Grow, Thrive for providing us with continuing education. And thank you all again for joining us. We're going to go ahead and get started. So I'm going to advance the slide. So if anyone is just getting to know the NEC Society, welcome. Thank you for being here. The NEC Society is a 501c3 nonprofit charity organization that's dedicated to building a world without NEC. We strive to advance NEC research, education, and advocacy, and we really work hard to bring together diverse stakeholders, including patient families who have been personally affected, clinicians, researchers, and others who care about babies and mothers and families. So here is our inclusivity statement. The NEC Society is intentionally committed to advancing diversity, equity, and inclusion, and not just within our organization, but really working to do that within the NEC community and the broader NICU community. So thank you I want to recognize our speakers for joining us and allowing us to help advance this work forward. And you can check out our statement on our website. I want to say thank you to my colleague, Erin, who's sharing links in the chat box for us. So if you registered early for this webinar, you should have received an email that had some resources, including these four here. These four resources were originally shared at Cpqcc's meeting back in the spring. And so we're really, I think, very fitting for today's webinar and great for us to review and to all be able to have kind of an understanding of what we mean. And this is what I want to highlight also, this glossary of terms. So what do we mean when we say anti-racism, when we say privilege, when we say structural racism? And so these are great resources that I hope you had a chance to review prior to today. If you haven't, the links are in the chat box, and I hope you will be able to review them after today's webinar. So we're going to do a quick live poll question. My colleague Erin is sharing a link in the chat box. So if you click that link, you'll be able to vote and share your response to this question. So does your NICU have a group working on health equity? And you can respond yes, no, I'm not sure, or if you're actively working on creating a group to address health equity in your NICU. So give everyone maybe 15 seconds or so to take time to respond. Okay. Thank you to those who have had a chance. We will have another live poll question later in today's webinar. So I'm going to advance to the next slide to keep us on time. So here are your speakers for today. We're really excited to welcome this really amazing team. We have Kimberly, Ravi, Yupin, Tamara, and Ashley. There's some incredible speakers with really compelling personal, professional stories to share. We're going to be hearing their voices in terms of what they experience in the NICU with their own children and families. We're going to look at NEC disparities, NICU disparities, structural racism. So we're really thankful to each of our speakers and excited to hear from them today. Just a quick reminder that the NEC Society is not providing medical advice, and we're really excited to hand it over to Kimberly to share her son Sal's story. So thanks, Kimberly, for being here.
Thank you so much. I want to thank the NEC Society for having me and the illustrious presenters that are here fighting for the health of our babies. I say it all the time because our babies are literally our future. So we have to do whatever we have to do to get them here safely and to make sure that they're receiving the best medical care. But medical care doesn't always involve the science and medicine, right? What we're talking about today is equity, and that's a part of medical care. And all of our babies deserve, equitable healthcare, access to healthcare, and their families deserve to be held with as much compassion and empathy. So I'm really happy to be here with you all and share our story. My name is Kimberly Nobod, as you've heard. I'm the founder and executive director of Sal's Light. We are a nonprofit that is located in New Orleans, Louisiana. And we serve all of Louisiana. We're based in New Orleans, but we serve all of Louisiana. And this is my son, Saul, here. He's a cutie. He would be 7 right now if he were still alive. It'd be his golden birthday. So my son Saul, our story begins like so many in our country. Saul was born prematurely, and as a result, he suffered a level 4 intraventricular hemorrhage, an IVH, and that ended his life just shy of a month of his birth, a month after his birth, sorry. And since then, it's been my goal to share our story and to put a face to the statistics of Black women in the United States who are over 50% more likely to deliver a premature baby than white women. Everyone thinks that they know what kind of people this thing happens to. Well, I'm here to tell you that it's me, an educated, economically stable Black woman in good health who supposedly did everything right. In the end, when it came time to start my family, my master's degree, my private insurance, my middle-class status couldn't save my son, right? And so that points to something that is really insidious that's involved in healthcare in our country and something that has been backed up by science and research. Like me, my son is a statistic. He's just one of the many Black babies who are 4 times as likely to die than white babies due to complications as a result of low birth weight. So with that goal in mind to tell our story, I founded Saul's Light, again, which is based in New Orleans. And so what we do is we serve the unique social emotional needs of NICU and bereaved families. This includes things like financial assistance to address barriers. These are things that keep families from being present and involved in their baby's care. We offer peer support to counteract the isolation and stress of the journey. We offer the Little NICU libraries, which promote bonding and cognitive development. And we also connect families to community resources, such as mental health therapy, support group, diaper banks, food banks, among others. So New Orleans, and actually a lot of places in the South, are somewhat unique in that we're probably the people that need the most help health-wise, but are the ones that get it the least, right? So for example, thankfully, I live in a state that accepted Medicaid expansion, but that's not the case for a lot of Southern states, right? And so that Medicaid expansion would really be very helpful for families that are in the NICU and that are in this situation and that are gonna take home medically complex babies. Lastly, we advocate for impactful policy change at the local and state levels. And I'm really proud of our latest victory, which is a Louisiana law that establishes a $2,000 tax credit for the family of stillborn babies. And our rationale is that families will be able to avail themselves of mental health therapists. They will be able to address the medical bills that still come in their baby's name. It will allow them to be able to funeralize their baby in a way that they feel comfortable with and to be able to move forward in their journeys with peace and with some aspects of feeling supported in the things that they've gone through. Saul's Light commitment to advocating for NICU and bereaved families are rooted in our 5 core beliefs. And these are the ones that everyone that works with our organization believes. Myself as a founder and executive director, but also as a mother and also as a human, as a community member that really cares about the families in my communities. The first core belief is that we believe that every NICU family deserves to be present and involved in their baby's care, not just the ones that can afford it. And so especially, we're thinking about families that are often overlooked or disenfranchised within the healthcare settings. This includes Black and Hispanic families, immigrant families, poor families, and those that are experiencing substance use issues. Secondly, we believe in the 3 E's of compassionate care. That is empathy, empowerment, and encouragement. Now, don't go and Google this and look this up. This is something that I came up with from working with families in our community. And again, our core belief of what I feel that they believe, right? And so when I talk about radical empathy, what I mean is that it's the acceptance of people's lived experiences, accepting them as the experts of their bodies, their lives, and their health, accepting parents as the parents of their children, right? They often know more about their babies because they're visiting and they're there all day looking at just this one baby, so their opinions, their thoughts, their beliefs matter and should be shared as an important part of the baby's medical team. The next is empowerment. We feel that parents should be empowered in their role as parents. They should be encouraged to speak up. They should be encouraged to perform caregiving tasks. What this does is creates a sense of intimacy that we often don't see with NICU parents because they've had some sort of disjointment of their parent-child relationship, right? Oftentimes, they haven't even yet held their babies. And so it's really an experience that is hard to start to feel like a parent right away. And so anytime that parents can, give their child the sponge bath or change their diaper or put a little hat on their head, right? Building those skills and encouraging that parental interaction is really, really important for the mental health of families. Next, we believe that healthcare professionals are committed to saving lives and maintaining the health and safety of all patients. That is never in doubt. I believe that everybody goes to work to save lives. And with that, right, in spite of this, we also recognize that disparities persist. And this is due to implicit bias and systemic racism. This is something that we really have to address head on if we really want to be able to see the change. Lastly, as a community-facing grassroots organization, Saul's Light believes that partnerships between hospitals and communities are the very first step in order to make lasting, equitable change in medicine. So I want to thank you all for allowing me to share Saul's Light, my son's light, with you today. I invite you to connect with me on social media, and I would love to hear about what you're doing to advance equity in your community. Thank you again.
Thank you, Kimberly, for sharing Saul's story and for the wonderful work that you're doing to support and advocate for families, and I'm sorry for your loss. I wanted to transition a little bit and talk about some of the disparities we see here in the United States among babies who die from NEC, and highlight some of the inequities. And I want to start by disclosing that I do serve on the data monitoring committee for an ongoing probiotic trial. So many of you know that health disparities are differences in health outcomes and their causes among groups of people. And this is a definition from the CDC. There's been a lot of work on trying to understand health disparities. I would say most of this has been focused on infant mortality and on prematurity, less so on necrotizing enterocolitis, but a lot of the same themes apply. As a first part of understanding health disparities is really to understand the differences in health outcomes, and here specifically about necrotizing enterocolitis. And so I wanted to share some of the data on some of the differences we see here in the United States on deaths from necrotizing enterocolitis. The first is where you live. And you heard Kimberly talk about some of the challenges of being in the South. I live in Georgia, and I am not happy with the fact that we are third, and we have the third highest NEC-related mortality in the United States. And if you looked at a lot of health conditions, you would probably see very similar maps from this. This is, I think, understanding we know some of the drivers that might be related to this. If you overlaid maps related to breastfeeding or poverty, you would see very similar data, but I think we still don't fully understand what explains this, why there's these geographic disparities. The other is disparities related to race. And here looking just at race of infants based on death certificate data, where from the CDC infants who died from NEC, looking at trends over time. I think the good story is we have made progress, and you'll see some more data from Jochen sharing the progress we've made in NEC-related deaths over time. But you still see this large difference and disparity in by race. And I would say that although we've seen progress in the last few years, particularly in 2013 and onwards, it really has plateaued and we have failed to make additional gains. Now, another way to look at the same data and thinking the lens of disparity is looking at what the ratio is of deaths from necrosis and colitis among infants who are Black compared to of white race. And again, you see that there has been some improvements where in 1999, about Black infants were 3.5 to 4 times more likely to die from NEC, and that has improved, but I think you and I would agree that this difference is still too great. Now, the same map I showed you, looking at it in a different way, and here looking not at which state has the highest NEC-related infant mortality, but what are the disparities? What are the disparities by states? And you see a different map and a different story here. This is looking at ratio of Black to white NEC infant mortality by the various states, and although some similarities, this is a different map, and I think this is another way of looking at this, and we don't understand why this is, why there is these differences. And I think the next step is from what I showed is in terms of the differences in health outcomes and their causes among groups of people. We really want to get at understanding their causes. There's been lots of work on understanding prematurity and infant mortality, and Jochen will share some of the data on what might explain this from his work in California. But I think that's an important step as we try to then move towards really the goals are that we want to achieve not just equality, but equity and eventually justice. And equity is reducing that difference where you saw we've gone from a ratio of 3.5 to 2.5. We want to improve and reduce infant mortality for all babies, but at the same time, we want to get that ratio to 1. And eventually justice, and we'll be touching on some of the societal barriers, breaking down some of the structural barriers that lead to these inequities. So with that, I'm going to transition and to Jochen, who's going to share some of the work he's doing in California.
Thank you, Ravi, for the presentation. Thank you, Jen, for inviting me, and Kimberly and all the other panelists for sharing the space with us this morning. As Ravi mentioned, I'll provide a little more detail on specifically disparities in NEC, but not only NEC, but then also thinking about like how do disparities or inequities in care delivery actually actualize what might be sort of some of the mechanisms that we might be able to address. So a bit more, I guess, of the general good news, similar to what Ravi showed for national data. Here's California data really over the past 10 years showing a kind of steady reduction in necrotizing enterocolitis. This is not mortality, this is just any necrotizing enterocolitis in babies less than 1,500 grams. And so almost cut in half over the past 10 years. And of course, every single case is one too many. Still, and this remains a harrowing disease to all of us healthcare providers and parents, but nevertheless, some progress has been made, which is good news. We looked at the differences in necrotizing enterocolitis by race ethnicity in California for these very low birth weight infants, and as you can kind of see in this upper panel, again, sort of through about a 10-year period, substantial improvement really across all race ethnicities here. Still a bit of a gap, particularly in the difference between white babies to Hispanics and Black babies. But nevertheless, again, a progress, which I think is something we should feel somewhat positive about. What might have led to this progress? I think there's been a lot of effort on human milk over these past 10 years, the emergence of milk banks as well, and the provision of human milk to these babies. And we can see that human milk has increased in all of the different racial ethnic subgroups that we were able to look at. Nevertheless, there's still a substantial gap here. And this is looking at milk use at discharge. And from McParker's work in Boston, we actually know that essentially with a little bit of effort, all moms, independent of their race, ethnicity, at least in Massachusetts, were starting breast milk feeding at the same rate. But particularly in vulnerable populations, there's a substantial drop-off in the use of human milk around a month of life, largely related to kind of social factors where people have to go back to work, etc., things that are interfering with their ability to provide breast milk to their babies. Nevertheless, with regard to the differences in breast milk by race ethnicity, we found that almost half of the difference was explained by between whites and blacks were explained by breast milk use. So this is a process where we could still really make a difference. Nancy Bogosian published this paper with colleagues from the Vermont-Oxford network. So this is national data looking at differences in race, ethnicity, and various outcomes over time. Here's necrotizing enterocolitis as one of the examples. And like the numbers are all kind of like small here, but you can sort of see that maybe there's a sort of slight decrease again in the racial ethnic gap over time, but maybe too small or too slow. Here's a different paper also looking kind of at care over time. This is from Colm Travers, and this is the NICHD network. These are essentially 16 children's hospitals from across the country. So a smaller sample and smaller babies. These are babies less than 1,000 grams. And you can kind of see that, for Hispanics, maybe there's like an upswing and then it seems to get better. Similarly for white babies, and maybe there's a narrowing of the gap. Overall, relatively steady rates in this sample for Black babies, maybe some mild improvement, but certainly not at the rate of the other two racial ethnic groups. So, maybe overall there's been some improvement and some good news, but maybe not quite where we would want to be, and some work ahead. So typically when I speak about racial ethnic gaps in care delivery in the NICU, somebody will feel like that this is not really the right thing to say because we treat all babies the same. And so we've done actually quite a bit of work to show that that's not true. We don't treat everybody the same. Here's actually a study from Dr. Brignoni Perez and Melissa Scala at Stanford, where we don't treat everybody the same, even though we feel like we might. So here's sort of the total amount of time spent on kangaroo care dependent on whether or not English is your primary language. And as you can see, people who don't have English as their primary language spend significantly less time on kangaroo care. This was true even after controlling for the number of times parents visited, or not visited as a bad word, so parents were in the unit. So even when you controlled for that, there remains a large gap. So these parents were not offered the opportunity for skin-to-skin care at the similar rate. Here's a study from Dr. Munoz. It's a couple of years old, also kind of expressing parental opinions on skin-to-skin care in one NICU here, and where mothers that were non-white expressed substantially kind of less engagement and or being offered and explained the benefits of kangaroo care compared to white moms. We conducted a qualitative study where we asked providers at a conference, some of them families, some of them physicians, nurses, nurse practitioners, kind of wide array at one of the Vermont-Oxford network meetings, to provide us with an experience on when they experience a disparity in care delivery. And we received over 300 stories regarding episodes of disparity that they had experienced. And Krista Sigurdsson was one of my postdocs, is a qualitative researcher, kind of grouped these stories into different subcategories. And essentially the way that we end up providing suboptimal care based on racial, ethnic, or other kind of overlapping dimensions of disparity. It's not only race, ethnicity, it's also class, it's sexual orientation, it's language. So there's other, people think of a variety of things when they think of the word disparity. But there's sort of three pathways predominantly that lead to worse care. One of them is neglectful care. The second is judgmental care, and the third is systemic barriers. And you can see I don't want to take too much time, we can talk about this in more difference, but I just wanted to provide you with two examples, one from neglectful care and one from judgmental care. And here's one of the stories from neglectful care. So I'm just going to read this to you. There's just a general observation. When I worked as a charge nurse, nurses tended to just ignore parents who did not speak their language. Often the use of a translator didn't occur daily for education and updates. These parents would have to sit by their baby's bedside and wonder how they were doing. These parents did not get the opportunity to interact and bond with their baby as a result. And here's a example of judgmental care. I see this all the time. The way we treat Black moms is definitely different than how we treat white moms. Age plays a factor too. Young moms are judged very unfairly. One Black mom was judged very harshly for being late for a feeding, even though she had a long and challenging transit ride to get to the hospital. A white mother who was late on the same day was greeted with sympathy. So I'd really encourage you to maybe look up this paper, and I'm happy to provide the reference to you again. You just email me or send you the PDF directly. These stories are really harrowing. In many ways, I feel like in my career, I've experienced most of them. And so I think from here, I'll just pass it along back to Jen. Is that right?
Now we're going to go into our panel discussion. Yep. Thanks, Ravi.
Thanks, Jochen, for giving us some more granularity on that. And I wanted us to have a chance to have a panel discussion. And I also wanted to let the audience know, I see some hands raised in the Q&A. Please share your comments in the Q&A or questions, or even stories you might have. We will have some time at the end of this webinar to touch on those. And so this is an opportunity to touch on some of that things that we've already highlighted and bring some of our panelists. And I wanted to start with Tamara and get some of the thoughts of Tamara, who's at Children's Mercy University of Missouri. And one is this thought of racism in medicine, and you shared this, which was a BMJ issue last year that highlighted the issue of racism in medicine, and also the lens in which we look at. And I wonder if you could speak more on this in terms of the way you view this and the lens in which you think of these inequities.
Absolutely. I want to start by just thanking the NEC Society for having this topic as one of their webinars. It really takes bravery on the part of an organization to confront inequity and racism head on. And so I'm very honored to be here today. You know, the thing that I want to make sure we discuss openly today is that medicine does not happen in a bubble. Just as structural racism affects almost all aspects of American life for minoritized families, structural racism also affects medical care. And this discussion of racism and anti-racism can make some healthcare providers feel very uncomfortable because this topic has become taboo in American society, and there's a lot of feelings of guilt and hopelessness. But I think as medical providers, we must learn to lean into this discomfort if we want to optimize the care that we provide to all babies. When I see this figure about the history of the Black experience in America, what I think about is how Black families are treated outside of the hospital and how that affects their care inside of the hospital. I think we can agree as parents and as providers that a large part of the NICU experience is having the emotional and cognitive bandwidth to be present with the medical team. It's very important for families to be able to trust the medical team in the ICU setting. But because of historical and ongoing racism, minoritized families can lack this bandwidth. In general, Black and other minoritized families have less access to wealth, less access to education, to flexible jobs, to stable housing, and to healthy food. So if you think about it on a population level, when life outside of the hospital is systematically more difficult and more stressful for minoritized families, we must consider that when we provide medical care. Minoritized families know deeply and understand the striking history that's displayed in this figure. And so if they have worries that their experience in medical care in the NICU may not be fair and equal because they worry their experience in the NICU will reflect the experience of Black families out in the larger world, we have to know that that worry is justified. And in the NICU, we have to make a space for families to feel safe to discuss their worries, to discuss their mistrust, and discuss how they think that their babies may be receiving inequitable care. I'll also say that in addition to minoritized families on average facing more adversity outside of the hospital, it's hard to admit, but it's absolutely true. They are often systematically disadvantaged within the NICU. One example of this is that minority families lack access to medical providers that share their cultural or racial background. There are many Black families and other minoritized families that can go weeks in the NICU without experiencing the comfort of a nurse or a social worker or a doctor that shares their culture or shares their language. For white Americans, this may seem trivial, but I really want people to reflect on the fact that it seems trivial because it's only because you are profoundly used to being surrounded by your like group, and you've never had to experience the vulnerability of being a Black parent cared for by all white nurses or an all white medical team. You know, segregation and the lack of understanding of structural racism really causes an empathy gap in the NICU. Providers can find it more difficult to connect with, to communicate with, and to have compassion for people from different backgrounds. So I'm hoping that this webinar by the NEC Society and other important webinars will allow providers the space to think about these things and to have these difficult conversations.
Thank you, Tamara. We're going to talk a little bit about kind of how do we put some data around this. But before we do that, I wonder if any of the other panelists wanted to touch on some of the points that Tamara raised.
I'll add on. Thank you, everyone. My name is Ashley. I just wanted to add on that what she said about empathy and having someone that actually looks like you and understands your background is so important for our families, especially because you don't know how to communicate already with a healthcare professional, let alone a cultural barrier between the two of you. And so it adds more stress to the family, and it also hinders them from wanting to express any type of guilt feelings that they have or any questions that they may have for you. So if you are able to um, try to make sure that you have someone that is appropriate for that family, whether it be African American or whatever culture you have in your NICU, that would be very powerful and a great statement to make to all the families that you are listening and you do care about them.
Thanks, Ashley, for really that important point. You've heard a little bit from Joken's talk about some of the measures, and one of the goals, we need to do better and we have to do better, but we want to make sure that we are able to measure that. So how do we measure improvement and know that our NICUs or states are actually advancing equity for mothers and babies? And so I wondered if you could share some of your thoughts on that. And I like this. This is something that Tamora shared, which was using rising tides to lift all boats, and thinking about improvement and kind of the aims with the very distinct equity focus. So I'd like our panel to kind of weigh in on this.
I don't mind starting. I absolutely love this paper, and I share it as much as I can with my NICU colleagues. The last author is Dr. Michelle Maria Pena. And the reason I love this paper is because pretty much every NICU around this country is engaged in quality improvement work. That mechanism as a process to improve patient care has been globally accepted. But what's interesting is that very few NICUs are doing this QI work with an equity lens. So how do we make sure that we're not only improving the care for all babies, but that if there are disparities in outcomes, the way Ravi discussed in the earliest slides, how do we make sure that those disparities are lessening with our QI work? So this paper talks about the fact that if you don't understand differences in your baseline QI measure, let's say it's breast milk use at 1 month of life, since we're talking about NEC. If you don't understand demographic baseline data, it is going to be impossible to understand if your QI intervention leaves disparities the same, improves disparities, or worst case scenario, your QI intervention was not designed to reach minority families and widens an existing disparity. And that's what this figure shows. And so when you collect QI data, it is very important to disaggregate it by the important demographic factors that we know are associated with disparities. That can be race, that can be primary language, that could be, if you want to get really creative and collect important social determinants of health data, transportation, job flexibility. If you do not disaggregate your QI data by these demographic variables, you will not have any idea if your QI intervention is worsening disparities. And so the goal of this slide and this discussion is to really encourage anyone who's watching that's engaged in QI methodology to read this paper and to bring a health equity lens to your projects, so that not only are we helping all babies, but that if disparities exist, we're decreasing the differences in health outcomes.
Thanks. I wondered if, Joken, if you want to, in California, you've worked on a disparities dashboard that does, I think, very similar, looking at data. I wonder if you could share some of your experience to some of the points that Tamara raised about looking at this and looking at interventions, how they might influence these gaps. And you're muted, Joken.
I have trouble with the mute in and out, but here you go. So yeah, I totally agree with Tamara. Measurement is really key. This is a snapshot of our health equity dashboard at Cpqcc. So all California NICUs, essentially all of them, all that are part of Cpqcc, which is more than like 90% of the NICUs in California, are able to see their data now broken down by race, ethnicity, and we provide them with a breakdown of what the racial ethnic makeup is in their NICU, and then they can look at a number of process measures. And below this row, it's a little small here, so I cut it off. But below this row, there's another row looking at different outcome measures. They can look at where their NICU falls, and we flag for them if there's a significant racial ethnic disparity. And even if it's not significant, statistically significant, because sometimes, as you can imagine, there's NICUs that only have like small numbers of specific race ethnicities in their NICU. It might not meet statistical significance, but nevertheless, you can still look at sort of overall differences in performance here and different groups, and take that as a starting point, at least for identifying where you might have problems, where you could find opportunities for improvement. And then through our data sets, we can also track longitudinally whether you're making improvement. So measurement is all quality improvement. Quality improvement, I think, we were a little bit positive in the beginning, saying like, hey, some of these disparities have narrowed and outcomes of NEC have improved. I think, since there haven't been really massive new improvements in science and in the care of these babies over the last decade or so, I think a lot of the improvement has been due to improvements in quality of care and a more systematized effort to do this. And I think this has also led in many ways, and there's some evidence in the literature for that, to reductions in disparity. So you might improve health equity by focusing on quality improvement, doing a good job in that. But it may not, that is not sort of an intentional equity effort. It would be better to really have, alongside your quality efforts, intentional efforts, as Tamara said, and really track outcomes according to subgroups in your unit.
Thanks, Jochen, for sharing that. And I wonder what, and maybe Kimberly can, as a former NICU mom, or even for families that post NICU, how do you think they can kind of partner and help in terms of the advancement of equity and some of this work in terms of reducing these disparities?
I think that's a great question. And the reason is because it needs to happen, right? But I think that in order for it to happen, hospital systems have to be prepared for it and have to want it, right? So what I mean by that is that there are probably a lot of hospitals that have a patient advisory board, but I'm willing to step out on a limb and say that patient advisory board does not include or does not reflect the population that is served by that hospital. I'm also willing to go out on a limb and say that the makeup of that board does not reflect people who are not going to just fall in line with whatever the messaging of the hospital is, right? And so I think that for any sort of patient family involvement to be valid and relevant, it has to include all the voices at the table. Some people that may have had a negative experience at your hospital, because how else are you going to learn from that? People that have, for example, even experienced loss, right? So I know from my personal experience, I've been on a number of these boards. Oftentimes, I've been the only Black person, the only Black woman, the only person who does not have a living child, right? And so that to me is very, to me, it speaks volumes of the commitment or willingness of the hospital to really listen and learn and impact changes within their policies, within their, frankly, customer service. And you can do that sometimes, right? When you have a really, really stratified city, which is what we have in New Orleans and in Louisiana. There are basically like, two big hospital systems. And so there isn't a lot of choice. And I think hospitals know that. And so you really just have to deal with what you're given. I think a lot of Black families feel that way. And they are not being asked about their experience. They're not being invited to be on, patient advisories.
I just want to add, I think that's where community-based and patient-led organizations can serve, like Sol's Light and the Next Society, where we can help to elevate those stories and those experiences so that we, I hope, can persuade hospitals to ensure that their Family Advisory Council truly reflects their NICU community is not just made up of privileged families. So thank you, Kimberly. I couldn't agree more.
Yeah, if I could just like piggyback on that, right? The systems, right? And when we talk about inequality, they're so tangled. So Sol's Light is a community organization, obviously Black-led organization, right? And so our goal is really to be able to bridge the gap in communications and relationships between hospital systems and the community, which in New Orleans is largely Black. However, I recognize that number one, there isn't another organization in all of Louisiana that does the work that we do, right? And then it is a great privilege for me to be able to do the work that I do. So it's not that people don't have these ideas or that people don't have these this sort of level of dedication and commitment. It's that people don't have time, right? So how many women and families have gone through this same experience that I've gone through, but they don't even have the time to assess their grief, reflect on healing, and then have the, whatever it is, financial stability, just, time to be able to push their efforts into an organization that does this, right? And so I think it even extends far beyond medicine in that we have to have community organizations that are led by people like me so that we can do this important work. And so, yes, everything that is going on in the hospital is very closely related to the community, and we need community leaders to be able to work together, right? But that's the problem. Where are the community leaders? There has to be more people like me. And so we need to make that possible as a society, or else this needle on health equity doesn't move.
Thank you so much, Kimberly, for that. And the babies and the moms and families of Louisiana are I'm sure, grateful for the work that you do. I wanted us to think, and Jochen, you touched on this, that sometimes, comes up. How should we respond to people who say, I treat everyone the same, or we don't have racism biases in our NICU? And Tamora, you shared this, about kind of thinking broadly about structural racism, implicit bias, and some of the things that go into this as we think about addressing and answering this question. So I wonder if you could share a little bit about how would you respond to that if that comes up when you're trying to do this work and work on reducing disparities in the NICU?
Absolutely. And Robbie, if you don't mind showing the slide with the circular pattern, I just think it's a very, very powerful figure to help us understand how, similar to what Kimberly said, all of this is absolutely related. And so in medicine, we've become very comfortable and very facile talking about this concept of implicit bias. It's a non-inflammatory concept. It makes people think, well, this is almost something that's outside of my control. These are biases that are baked into me. And I really hope that as a community, medicine can go through this complete circle, really begin to learn and understand about the underpinning of our implicit biases are structural racism. And so, the way that you feel, I'm just going to say as a medical provider, the way that you feel about a young Black man who presents at the bedside as a new father, the gut reaction you have to that person as opposed to a young white man that presents at the bedside as a new father, it's not that this implicit bias comes out of nowhere. This implicit bias is ingrained into every single American based on the insidious messages that we all receive as American citizens. The insidious messages include, who belongs in jail and who doesn't belong in jail, who goes to college and who doesn't go to college, who is a criminal and who is not a criminal, okay? These are the types of insidious messages that are born out of structural racism that are the root of our implicit biases. And so until we can change the conversation about who is valued, who is worthy, who is deserving of your time and your empathy, we will never be able to address these implicit biases. And so I love this figure because it forces you to cognitively relate these two things that historically in medicine, we have been reluctant to cognitively relate. And I think it's really important that in medicine, we move beyond this comfortable conversation of implicit bias. It is far time we move beyond that comfortable conversation and really start to talk about what are the structures, what are the policies, who is in power, and how does that reflect the medical care that we provide?
Thank you for that perspective. And I'm going to transition a little bit and talk about really, if we want to address this, I think all of our panelists, as you've heard, we really have to think outside the walls of the NICU. And this is difficult to do for many of us that do work within the walls of the NICU. And really the importance, as Kimberly said, about our community organizations, about the people working in the community, about nonprofits that are doing this work. And Ashley, you lead one of these organizations. And so I wanted to bring you in here and share some of the work you're doing and how we can really think about kind of working outside the walls of the NICU in terms of what we do and partnering with some of these organizations that are outside of our hospital systems.
Yeah, thank you so much. It's important that we work with community-based organizations because it not only, one, helps the hospital release stress, especially on their workers, as well as helping the families have a way to share with someone who looks like them, especially if they are able to pick the organization. So as I share my screen, I want to start and say thank you, Ravi, for introducing me, and thank you, Jennifer and Next Society, for this wonderful opportunity. I am the founder of the Alliance for Black NICU Families, co-founder, and also the founder of Globe Preemies. I am the African-American mom of 3 children, all born premature. My children were born in 2 in California and 1 in Texas, but I had 3 pregnancy experiences, and 1 Louisiana, 1 started in Texas, and 1 began in California. I never ended with the same doctor that I began with, and I also never was able to have a baby shower or had a very pleasant NICU experience. With that, I will begin with the Alliance. My name again is Ashley Randolph for Globe Preemies, and I co-founded this alliance with Deb DeSenza from Preemie World. Why now? Because we are trying to make change for the last 450 years that African Americans have been impacted. Professionally, we are impacting national changes by uplifting Once Upon a Preemie Academy. We are also mandating national education for professionals, And we are also beginning to give many grants to our African American NICU-led founding members. For our parents, we are allowing access to educational materials, as well as giving them practical support and grants. And we have just begun to give them breast pumps as well. We have a long list of members of the Alliance, but most importantly, these are our founding members. I am very happy to have Saul's Light as one of our founding members. And some other names that we have is Connect to NICU, Eli Collins Foundation for Premature Babies, Families Blossoming, Once Upon a Preemie, Pebbles of Hope, Mended Little Heart, Preemie Crystal Ball, Preemie World, and more. We have a long list of partnerships. This list has not been updated in a while, but our first partnerships that we've got with our Alliance included 2020mom.org, I Am a Miracle, Hand to Hold, Free to Read, National Coalition for Infant Health. We are working with the government as well right now, so we have a lot of hands helping us right now with making this national change. Glow Preemies. I started Glow Preemies after my second child premature. The future is now. Our most important work that we're doing right now is is our NICU city. Number one, we're making change to the healthcare system and how we view it. We're also trying to improve future generation lives, and we demonstrate a world that can work together. I am also currently your Mrs. America Virtuous Woman. Our NICU city has a 3-step program. So our 3-step program starts with high-risk pregnancy and those families who are currently in the NICU. They get workshops, doula support, transportation assistance, mental health therapy, and more. We also send care boxes and deliver directly to the family's home after they leave the NICU until the child turns 1. We are actually working on sending out 2,100 care boxes for the holidays to the 30 hospitals. They have the option to get them, and we will start reaching out to them in 2 weeks to see if they will like the care boxes for their current NICU patients. Step 2, it includes from the NICU discharge until 5 years old. That includes sign up for all workshop care boxes and assistance from before, but also includes virtual home visitation, financial support, career support, and more. Step 3 is from 5 until 18 years old for the NICU child, and we include tutoring services, workshops, IEP review, transportation assistance, and more. We also include all of our partners from the Alliance for Black NICU Families. So we, as Glow Preemies, we are nationally, and we do have families in every single state, but we also know that some families want to work with local communities. So for instance, like Kimberly, she does amazing work in Louisiana. If we have a family who's in our 3-step program and they say, hey, I really want to get mental health support, but I really want to work with a community-based organization where I am, then we will refer them to Kimberly. So that is where we work all together and show a world that works. We also work with healthcare professionals. So whether you're a social worker, physician, NICU nurse, you are able to automatically submit your family into our 3-step program, and you receive a healthcare professional packet letting you know how to do that. Company overview. I need to update this as well. We became a 501c3 in 2020. We were founded in 2014. We are in 51 states. We are now partnered with 30 hospitals, and we have support from 20 hospitals. As Kimberly mentioned, I will mention this a lot from Kimberly because she is a parent like me. As she said before, it's up to the hospital to really say if they want to make the change. But what we have learned is that if the hospital does not want to make the change, the NICU nurses have begun making their own little community outside of the hospital where they are reaching out for these resources and bringing them in that way. And we are also connected to 2 research universities at this moment. There is myself and my 3rd preemie. These are also two of our care boxes that we've given out last year. The top one is Have a Holly Jolly Christmas bag that came from Glow Preemies, and we put a lot of educational materials underneath, and we have some free goodies to give to the families, and that was from last year. And then we also have our boxes. This was one of our first boxes that we did where it was Jules hand glued onto it, as well as a whole bunch of materials for the families and more educational resources. Millennials are redefining healthcare. And so with that, we decided that NICU City needs to have everything technology. So what we're doing right now is building our own little tiny village, and it will be based in Sacramento, will be the first one created, but we are already working on building it in every other state following the one in Sacramento. We have 3,000 families in our program as of June, and we are hoping to have 1 million families within the next year to 2 years. And I'm sure you're having questions of how do we expect to get there? Well, Glow Preemies NICU City, we will provide shelter for the families if they need it. And as long as the 3-step program is available, we have everything else that they need: mental health, career, temporary housing, and anything that may need, such as food or diapers or etc. We are planning to try to reduce the cost for NICU families substantially by using our NICU City versus a standard NICU stay. Molina Healthcare is our partner and our complete supporter of Glow Preemies and NICU City. We work with Molina Healthcare 100%, and they refer their families to us, as well as will work with us on families that we have who are uninsured, if they are in any state. Our leaders. Myself, I am a 3-time NICU parent, and I am the founder of Glow Preemies and co-founder of the Alliance. The person under me who helps me with so much is Nicole McCrae. She is also a NICU parent. She has a past experience, and she is also the CEO of Free to Read Services, which is a tutoring services that specializes in helping children who were born prematurely. And if you need any more information, feel free to reach out to us at glowpreemies.org or blacknicufamilies.org. And I thank you so much for watching this presentation.
Thank you so much, Ashley. I really appreciate you being here and sharing your story and the work that you're doing. So we are going to do another live poll. I believe my colleague Erin is sharing a link in the chat box. So if you click on it, you should be able to answer this question. Which community-based or patient-led nonprofits are you connected with or are you familiar with? And I'm going to let this go for hopefully 15 to 30 seconds. I'm really hoping to get a robust collection of organizations and charities and nonprofits that we can share and highlight here. So I see Sal's Light, Glow Preemies, NEC Society, Once Upon a Preemie. We need to highlight the Alliance for Black NICU Families, Hand to Hold, Homeless Prenatal Program. Wonderful. So let's keep them coming. I'm going to leave this open for a few minutes. PGG, those are our colleagues in Brazil who have a NEC-focused organization. Great to see them represented here. The NICU Parent Network, that's a coalition of organizations like ours. I know, I believe Glow Preemies, Sal's Light, and the NEC Society were all member of the NICU Parent Network. March of Dimes, okay. Great, and I love Hand to Hold. And I'm learning about some new ones here. There's a few on here that I'm actually not familiar with, so I look forward to checking them out. NEC UK, that's another NEC focused charity in the United Kingdom. Great partners of ours. Anything else that you can think of? Great. All right, I'm going to go to the next slide. Thank you so much for sharing this with us. This is wonderful. So I want to highlight some things that we can do today. We've shared a lot of content, a lot of information. And so where can we actually start? What can we do to advance equity now? So one thing that we can do is work to, if you're in the NICU, build a family advisory council that reflects your NICU population. If you're a patient family, you can work to help your hospital get there. If you are a healthcare professional, you can encourage your team to go in this direction and make sure that the families who are either recruited or volunteering or serving in that role actually reflect your NICU population. Making sure that our materials for families are offered and provided in multiple languages is really important, so they have access to information that they need to serve as informed members of their baby's care team. We can also work to discover some really exciting community-based organizations and resources like the ones that we just showed, and working to connect with them. We can make a commitment to continually learning and voting and donating and speaking up for the causes that we believe in that are so important to our babies. And also interrupting bias when we witness it. And I'm going to share some examples and some language that we can actually use. And I've actually used some of these phrases myself where I've been in situations that have taken me by surprise. And I know that sometimes I have to pause for a moment and think to myself, did I really just hear that? And then make the decision, do I stay quiet and do I remain complicit, or do I actually speak up? And I hope you will join me in actually speaking up and interrupting bias and racism when we hear it and witness it. So some that we can use: that's not okay with me. I didn't realize you think like that. I need to hold on and process what you just said. So some really great resources. And I believe my colleague Erin is sharing the link in the chat box where you can find more about the organization that put these together. Some more, I need to help, you need to help me understand how you're thinking. I'm not comfortable with that. So again, just some language that we can use to interrupt bias and racism when we hear it from our colleagues or just people who are around us that we're interacting with. So I'm really excited now to open it up for our Q&A with our participants. So I'm going to ask all of the panelists to please keep their cameras on. I'm going to stop sharing my slides, and I know we have some questions that have been shared in the Q&A tool and in the chat box. So we encourage you to please interact with us. And I'm going to stop sharing my slides so we can just see the panelists now.
And so please share some of your questions. I thought we could start with the first question here and your thoughts. The question is, do you believe that implicit bias training should be implemented for all hospital staff, and what impact it has, and your thoughts on that? And so I'm going to open that up to the panel.
I'm happy to start. I will admit that I'm very dubious about the true progress that can be made with implicit bias training. It has been ubiquitous in medicine for at least 10 years, and we have not seen real improvements in most healthcare disparities despite near universal mandatory implicit bias training. And the reasons for that are many, but I think one of them is that it doesn't push hard enough. It doesn't put people in any kind of zone of discomfort. And so it's impossible to grow and make progress if you're sitting in a zone of comfort. So what I really started moving towards are concepts of structural competency. You know, medical students, residents, fellows, are they structurally competent? Not are they aware of their implicit biases, are they structurally competent? And what I mean by that is, do they understand the societal structures that directly impact health? And do they understand that racial disparities are not biologic? They are not rooted in differences between different bodies. They're rooted in the inherently different experiences of living in this country as a different race or a different primary language, of being in the NICU as a different race or speaking a different primary language. And so, you know, I recently co-created a new curriculum for our medical school here in Kansas City. And the curriculum is called Anti-Racism and Cultural Competence, because years of implicit bias training has not improved the outcome for these most vulnerable minoritized families. And so that's my very honest response to that question.
I couldn't agree with Dr. Lewis more. And to be honest with you, I think implicit bias training sort of absolves the practitioner from their thoughts and actions, right? So when we hear implicit, we think, well, you know, it's my subconscious, there's nothing I can do about it. But then you have to take that next step and understand that surely, right, you can't control your thoughts, but you can absolutely control your actions, right? So you need to know how your actions are indicative of your thoughts. So you have to be able to take that next step and realize that, you know, even if you have a thought that is not a good thought, that is a racist thought or a nationalist thought, whatever the ism is, you can also choose, like you can confront that thought and send that thought on its way. And then in your action, be a better healthcare provider, be a better person, better nurse, better, you know, whatever the position is. But no, you don't get to throw your hands in the air when you say it's implicit, it's innate, I can't control it. There has to be more than that. And so I think, yes, there has to be that next level of where people are actually confronting and doing things and becoming, right, becoming better.
Yeah, I've been very conflicted about anti-bias training. I think, you know, there's a whole history here of cultural competence training that we, you know, underwent maybe 20 years ago. And the literature on its benefits is rather thin. You know, like mostly the literature shows that people who do it are more culturally competent, but it doesn't really benefit patients. And I'm worried that currently in the kind of health equity field, we're making a mistake again to put all of our bucks on education and changing hearts and minds. And I actually don't think that changing hearts and minds, you know, while maybe eventually necessary, is going to be the most effective approach for change, at least in the more near term. I think there's a lot of room that can be gained through, you know, technical and structural improvements, and in the really sort of adaptive work, I think that you're all talking about, the changing of hearts and minds. It's really hard to do, and will require kind of ongoing iterative work. But there's a lot of evidence that you can improve on things as they currently are and make big differences to outcomes of vulnerable populations without needing sort of the training. So in a sense, it's necessary but not sufficient. And I'm not even like I'm even worried about the necessary, because I do also hear people getting really frustrated with these type of trainings, and I think we are actually turning off people that could be allies in our work by through some of these things. So I feel very, very torn about these kind of mandatory trainings. It's mandatory in California now, right, as a state law. So, and it's only perinatal providers, as if there's like no disparities in other like areas of healthcare. But now all perinatal providers have to sort of do mandatory anti-bias training. I don't think that by itself really helps a lot of babies out there and a lot of moms. But obviously it starts a conversation, which is sort of not a bad thing either, right? So like there's an elevated level of conversation about these things now that didn't exist before. And so maybe that's a positive.
To build a little bit on Joachim's comment, you know, thinking about moving away from changing individual hearts and minds to really looking at structural and policy changes that provide incentive outside of your belief system. One way that the leader of our health equity surveillance system at our hospital talks about it is, you know, the same way that we implemented safety. You know, let's just talk about CLABSIs. central line associated bloodstream infections. It doesn't matter if you've learned about CLABSIs, if you believe that they're important. Once the federal government identified that as a measure of quality of deliverance of medical care, there was a remarkable and intense focus on CLABSI and how do you minimize it and decrease it and eliminate it in order to stay accredited and in order to get paid by the insurance companies. What if we did something as radical as putting health equity in that same space? What if we did something structural on the policy level that said, if you don't measure your outcomes by race and show that disparities are improving over time, you will get penalized the same way as if you're not measuring your CLABSIs and showing those go down. So that's, we're not quite there, but it's heartening to me to hear Jochen say that and to hear people speaking about the possibility of putting health equity on that same level of importance as safety.
Absolutely. If I could just tag on to that, because I thought that was so profound, right? We got here by intentionality and by creating these structures and these systems. They're not going to undo themselves. So it's going to take deliberate action. And I just love that, right? We have to do something. We're not going to wish our way out. And so I'm glad that there's a higher consciousness of it now. It's like my experience. I hate what it took to get here, right? I think the thing that really kicked all of this off and really sort of made our society fertile ground for these conversations is the murder of George Floyd, right? I'm sorry that's how we got here, but we're here. And so now we need to take that baton for moving racial equity and run with it. And we have to teach people how to do it, and they have to do it. And we absolutely need to penalize them if that work is not happening. Because if it's not happening, we ain't going nowhere. Nothing's gonna change. And so I love that. I couldn't agree with that more.
I love it. Financial incentives. It's been a long while. I feel like when I first started in healthcare, I was actually interested in financial incentives. It's obviously the value proposition, and that's what you're talking about, and health policy has moved that way. There are some caveats in that we'd have to consider carefully, because sometimes the poorest hospitals, taking care of the poorest populations, are the ones that get even more left behind by some of the financial incentives, because they don't have the resources to throw after these things as wealthier institutions have. So you have to there'd be a lot of devil in the detail on these things, but in general, I think it's a wonderful idea to think about how can we set the incentives for hospitals to work on this on this goal.
So I wanted to build on some of the question on implicit bias training and some of the discussions that were occurring in the chat about how do we get kind of the languages that are surround this improvement work and kind of develop kind of shared language and some of the, and I don't know if Kimberly or Tamara, if you wanted to share kind of this term, for example, of minority and some of the comments about that, and maybe more broadly about having those conversations and maybe how you have that so that it becomes, because it might be uncomfortable conversations initially when you're having it in hospitals or in NICUs. I wonder if you could touch on that.
Yeah, I'm happy to start. Over the past 5 years, as I've delved more into this work, I have made an extremely conscious shift in my language. In every single opportunity, I take the blame off of the oppressed population and explicitly use the language that appropriately describes the situation. So when you call groups of people minorities, it's like that's it's like an intrinsic status of theirs, and somehow they're lesser because of it, or they're more lazy because of it, whatever the stereotypes that comes with it. But if you use the term minoritized, that means that someone in power has labeled a group of people with this term And all of the bad things that come out of being in that labeled in that group are not the fault of the group, but of the people that have labeled them this way. Another really good example of that is, they'll say, Black women are underrepresented in prenatal care. That implicitly places the blame on the Black woman. So instead, I'll say Black women are historically excluded from optimal prenatal care. No Black woman decides they don't want optimal care. They're historically excluded from optimal care. So really being intentional about your language and taking the implicit blame off of the oppressed and placing the implicit blame on the oppressor.
Yeah, and I just want to add also, that's why it's very important for me to be an example of what a statistic is, right? We can take that word and run with it, but it's often attached to a set of ideas and stereotypes that we have about a group of people. And a lot of people think, I've heard it, people have said it to me about the kind of people that they think give birth prematurely, the kind of people that have low birth weight babies or babies that die. Well, I'm here to tell you it's me. And so there is proof, right? If you would interact with me and feel that, okay, this person is my equal, this person is smart, is educated, X, Y, Z, surely this person has had optimal prenatal care or have had all these things, right? But this couldn't happen to her. It does, and it did, which is even more proof of this sort of minoritized status, right? And so racism is real. Black women not being believed is real. Black women not being heard and being treated with the utmost care and respect is real. And our babies being born prematurely and dying is real. That hasn't changed in about 20 or 30 years. What is that about? There's really not a reason other than racism that Black women, despite their education, despite their income, have the same birth outcomes or less, right? Lesser birth outcomes than white women who don't have that same education and don't have that same income. And so I think that there is a lot of power in language. And I think it's really very important too, that when people see me, they don't try to separate me from other Black women that are having premature babies and that are losing babies. We are all the same.
I've never liked the term minority. And I'm sorry if I've used it. Like sometimes it's hard to know, maybe what the right term to use is. And I know there's just a JAMA issue just came out like 2 days ago or something like that. Then that actually has an article about what you should use as language when you submit articles. So I'd encourage everybody to look at that. I think it's freely available on the web, and maybe Jen, you could share it. I still am kind of wondering, so personally, like what the right term is. Minorities clearly isn't great. Like Hispanics are like the majority now in like many states in the South, and white people are the minorities. So minoritized is maybe a better term, but then even minoritized, like does that still even like meet like the right goal for Hispanics who are actually the majority? So it seems even like still seems kind of weird to use that term. Vulnerable populations kind of seems not great either, and underrepresented minorities doesn't really seem great either. So I still struggle with the right term, and so please, please help me out if you can. What do you think the best term is? Like the whole BIPOC doesn't seem great either. Like so, there's like it seems like every term has valid criticism sort of to it, and I'm not certain what term to use personally.
I would encourage people to call people what they are, right? I'm Black, so I could be called Black. I could be called African American. And if we're talking about Hispanic people, then let's call them that. If we're talking about Latino people, let's call them that. If we're talking about, I don't know, Afghans, let's call them that. I think just calling people what they are and giving that space for existence. And yes, it might take you an extra 10 seconds to list the groups that you're talking about, but you should list the groups that you're talking about, right? We are not just all a blob, right, of people of color. We all have our own individual identities. And so, yeah, I think calling people what they are is very important. Let's not, sort of use those broader terms that are like taking the place of the new, that is now the new language of the old language minorities, right? Which we're not. And so one thing I put into the chat is that people of color are a part of the global majority. There's certainly more of us than there are of other people of other descent, white or European descent. And so, yeah, I think take the time, list the people that you're talking about. We deserve to be recognized.
I think one term that I've heard that I don't like either is non-whites, to try to capture everyone who's not white. And it's almost like normalizing whites and unnormal. And so I'm like, that's not it either. So I've seen that. I'm like,
because
that is
it's
not
still
it.
Putting our identities
Exactly
in proximity of whiteness. Whiteness is
Yep.
centered. Whiteness is the default. And we have to change that. We have to be intentional about changing that. All of us are smart people. We can learn some new words and some new terms. It'll be worth the effort.
I wanted to touch on something that struck me when Ashley talked about partnering with 10 hospitals. And, I think a lot of the work outside the walls of the NICU that, this is the sources that might relate to housing or transportation, other things that hospitals are just not very well equipped to. How did you establish those relationships with those 10 hospitals, and what how did that come about, and how do you build those types of engagements, to try to bridge kind of the disconnect that happens, across the, from the hospital setting to the community?
Okay, so thank you for that question. So our current list is 30 hospitals with support from 20, with many more, at least one in every state is looking it over to see how they can partner with us or be of support with us in some way, somehow. So I'm hopefully we'll have the whole nation covered. You guys ready for the answer? Just ask. So what I literally do is, whether it's LinkedIn message, I don't care if you have a Facebook. So I actually learned this from my last job, which is my kids' school. I was shadowing the president. Her name's Margaret Fortune. She's African American, and look her up. She's amazing. While shadowing her, she would actually go and knock on whoever she's looking for on their door and say, "My name's Margaret. This is the school I'm having. It's for African Americans, bridging the gap, and I need your help. So how are you going to help me?" And it worked. She has a phenomenal school district now in Northern California and just starting in Southern California. It's brilliant. I love it. Kids graduate high school with their associates. Most of them are graduating with 2 associates. So I learned from her. So now what I do is, okay, I reach out to all the presidents. I reach out to the social workers. I reach out to the NICU nurse, and I say, this is what we have at Globe Preemies or the Alliance. How can we work together? You need this. We can take some of the pressure off of you. Now, it really helps now that we have Molina Healthcare in our corner. So if we aren't able to provide something immediate, they are. So we are able to take as many families as we need now and make sure that they're all taken care of. So that's a good point to put in, when I'm talking to them in the first few sentences. So that's just all we do. Just be upfront, because like everyone here on the panel said, language is important, and their best language is, I need to know what I can do to fix this now. So instead of me going around the question, I have a solution. It's not going to be the perfect solution for everyone, but I have a solution for part of your problem. Let me take the stress off of you, and it works.
Thank you. All right, I think that wraps up our discussion. Those are some wonderful questions and comments and amazing work. So I'm going to just share my screen. So I want to first thank everyone who participated in today, our amazing speakers with their incredible stories, and wanted to say that we do have our webinar series available on our website. So today's webinar has been recorded and it will be available in the next couple of weeks. And the other 2 webinars that we hosted this summer are currently on our website. So I wanted to just say thank you so much for joining us, and stay tuned. I'm going to launch a quick poll where you can give us some feedback. We really count on that. I'm not sure if it'll work, but if not, you'll get an evaluation. So thank you so much again for joining us, and take care, everybody.